All right, thank you very much. I appreciate it. There are so many intellectual people here today, and now they have the orthopod that gets a chance to talk and kind of give his 2 cents on something. So hopefully I don't bore you to death. I'm fortunate I'm talking before lunch because I know that it would be a little bit more sleepy of an audience afterwards. So again, I appreciate the introduction, and we're going to talk about comprehensive spine care. So I start with this slide. I always like to include my family while I can, but the most important thing is family here. This is just a little introduction to myself. I am an orthopod, so I focus on the musculoskeletal side of things and leave the complicated stuff for the neurosurgeons and neurologists. I am a millennial, so if I tweet in the middle of the talk, I apologize. I trained at Rothman Institute, so I have an appreciation for throwing a bunch of complicated graphs on the slides, and I'll probably do a couple of those here today as well. And I'm just getting started, so I really appreciate the privilege and the opportunity to be a part of this team. So this is my wife, Laura. That's my daughter, Margot, who is crying, and my son with a big smile on his face. We are representing the Paw Patrol during our latest Halloween. So Margot here is kind of showing what the spine patients look like when they come into my clinic. The first slide on the left shows a picture of when I tell them I'm not going to refill their narcotics for the 8th time. And then this is after the actual physical examination on the right. So what you'll find is that these problems are really frustrating. This is a challenge for these patients. They are unhappy when they come and see me, and they've been unhappy for a long time. Tommy here is exhibiting some other parts of here. The spine and musculoskeletal problems in the cervical, thoracic, and lumbar spine are hard. They're hard to deal with. They are challenging. A lot of the neuropathic pain that they experience, even if we have a clear-cut sign of impingement in the foramen, can be challenging. They don't follow the rules like Tommy here when we tell them how to bathe. And then you can find yourself hitting kind of a glass window here and sometimes just can't quite get through exactly what you're trying to do. These spine problems are time consuming. I remember the first time I was in the emergency department at Jeff as a resident, and I looked at this form and I thought to myself, oh my God, I am never going to do spine. And I thought that there was such a complex amount of things that need to be assessed at the same time. And this is really only for trauma. This is kind of your ASIA scoring scale. And think of all the things that you have to do to commit to the spine physical exam and understanding how things are going. So the goals of the talk are first and foremost to keep you awake. I feel very confident about that. We're going to go through the impact of back and neck pain societally. That's where I dump a bunch of slides of graphs that will bore you to tears. And then hopefully we'll take it back and go through the healthcare climate. And then finally, we'll discuss actual comprehensive spine care and where we're going to try and treat this major problem in society today. So here's a few facts. This is the #1 worldwide cause of disability. 264 million lost workdays. And I'll have a slide later that shows how much, that's almost 50% of the lost workdays in the United States in 2015. And this will cost approximately $980 billion healthcare dollars, 5.7% of the GDP. I chose to do most of these facts pre-pandemic as some of these numbers have been skewed. So most of these slides will be in the 2009 to 2015 era. Here's a slide here that shows just the trend of increasing amount from 1998 to 2013, physician visits for back and neck pain. It's going up. These are the hospital discharge status and diagnosis. The proportion of hospital discharges overall, 61% of discharges are coming from back pain in most of these hospitals. And you're having it in the demographics of male and females, 45 to 64, but also 65 and over. We're an aging population. This is a graph that shows the number of millions of days of work lost. The red is just back pain. So 264 million days out of the 550 or so are contributed just for this problem. Then we go into neck pain. It was 1.8% of the healthcare visits in 2013, 86% lifetime prevalence in the US. And again, this slide shows again that of 21.4 million visits, a large amount of these are in the office. So there's a lot of these that are subacute, and we have to understand that we have to be able to understand the pathophysiology of neck pain, when patients need to be seen in the hospital and when they need to be evaluated, because the risk of disability is high with myelopathy and certain pathologies that occur in the cervical spine. This is another slide that goes through basically the increase in the cost and the number of percent discharges between neck disorders and neck injuries, and we see that those numbers are increasing overall. So just to be obvious here, we're getting older, we are getting sicker, we are spending a ton of money on this. So again, another slide here. I want you to just basically look at the yellow bar versus the red bar. The red bar is patients that are 65 and older, and the yellow bar are patients that are between 40 and 64. And so you can see 45 to 64, and you can see how the trend is coming up that we are aging population here. The direct costs and for spine have increased significantly over the last decade or two, and this is illustrated here. Again, this is incremental aggregate direct costs, and this is in B as in billions of dollars, and we're up to 315.4 billion, and that number, I guarantee, is significantly higher over the last 5 years. And again, I think this slide is one of the most depressing slides that you're going to find here, and again, we see that the adult obesity rates are continuing to be a major epidemic, and when we are trying to treat patients with a complex neuropathic problem involving these type of impingements and foraminal stenosis or spinal stenosis, not only are these patients limited in their function due to the actual musculoskeletal system, but then they tack on 50 plus pounds of overweight that they have to maneuver, increasing fall risk and increasing the challenges perioperatively. So again, let's review here. Everyone gets pain, costs a lot of money. And we're trying to manage this in a sicker and more obese population. So what can we do? How can we fix this problem? Well, the first thing is we have to change the paradigm. We have to understand why this is going on, and we have to change our thought process. Originally, a lot of times we would say that you go to quote unquote the expert, the first person that you need to see, and have one person be leaned on as the responsibility for all of these problems. So I offer a different plan. Apology to all the Christopher Reeve fans. We are not Superman. This is not what we're trying to do. It's not a one-person job. This is not something that can be done alone. We're the Avengers. We want to create a center where we have a group of people working against this, because it's not just one enemy. It's not just one problem. We're talking about millions of people every year dealing with back and neck pain that is significantly disabling their ability to get around. And we need to treat them, and we need to treat them appropriately. And it takes a team. We can't focus on just doing things by ourselves in silos and hope for the best. So I offer this definition of comprehensive spine care. It's a multidisciplinary approach, managing the disorders of the cervical, thoracic, and lumbar spine by individualizing the patient care, focusing on what their problem is. And we have to stratify the interventions. But you can only do that if you have that team. If you don't have a team, you don't have the different options of interventions. So then you create a situation, much like many orthopods think, you're holding a hammer and you're just looking at nails. And that's not the case. We want to have the screwdriver. We want to have the osteotomes. We want to have the mallets. We want to have different ways. You have to be a little bit more subtle. It's not just focusing on surgery as the treatment option of choice. So I think this is a very helpful slide, because this is kind of the core of what comprehensive spine care is going to require. At the base of this is primary care. A lot of these problems are not surgical. In fact, well over 90+% of patients that are having these problems are going to have something that does not need surgery. And there are a number of reasons why, and we'll go through those. So primary care is at the core of a multidisciplinary team when you're creating a comprehensive spine center. It then goes to the next group, which is the physical and occupational therapists. I can show you that obesity slide till the cows come home, but if we don't have these patients in motion, or these patients appreciating where the musculoskeletal impact of this is going on, I think we're limiting ourselves in terms of management. Then I think is perhaps one of the most important rungs is neuroradiology. We can't undo an MRI, and we can't undo what we see on an MRI. And I think it's important to decide when the MRI is going to be utilized and what it is going to be utilized for. These are highly sensitive but poorly specific tests. So oftentimes you'll find patients that have findings on their MRI that may have nothing to do with the problem that they're having. Nevertheless, these patients are then getting shuttled into a perioperative period and may not get the treatment that they actually needed. We then go into advanced diagnosticians. So there are so many overlapping findings. I always think about and tell my patients about Looney Tunes, which is one of my favorite cartoons, the one with Bugs Bunny and Daffy Duck where they're in the woods and there's a sign that says rabbit season and duck season. Oftentimes I've got patients that are pointing to their groin or to the side of their hip and they're saying, "Doc, my back is killing me." But it's actually their hip. They've got end-stage osteoarthritis, their hip. I say it's rabbit season. You got to go see the total hip doc and we'll take care of this. And then we'll see how you do on your back. Or vice versa. The patient will be cringing and pointing at the side of their hip, which is not really pathophysiologic for hip arthritis. And they'll tell you, "Doc, my hip hurts," but they won't replace my hip. It's because their hip is fine. They just have some radicular symptoms that are coming from L4 or L5. So you have to understand that, and that's where the diagnosticians and having a team of referrals is going to be critical. And if you can keep this all subdivided within your own group, it makes a significant improvement. Then we get to the physiatrists, and again, this is very similar to the diagnosticians, where you are evaluating and intervening on certain ways to be able to evaluate whether or not these radicular symptoms are getting better with epidural injections, whether there are facet blocks, and there are numerous other different treatment options that then will ultimately lead to the top. And the smallest font needs to be the surgeon. The surgeon is the last resort, and that's the paradigm we need to understand. Is that patients can go through this process over the course of 9 to 12 months. They get better. Sometimes they get completely better and then they can live with their lives. But you have to be willing to kind of have this give and take that is involved with the multidisciplinary team. And at the core of this is communication. You need to talk with all of your team members. You need to be in the same space or have the organization. It takes significant effort. And one of the things that irritates me to no end is when a patient comes in and says, "Well, the neurologist told me X, and this EMG study told me Y." It should not be the patient's job. The patient should not have to explain the pathophysiology to me. It should be my colleague. We need to work together as a team because the patient didn't go to medical school. The patient is not the one who's getting paid for the consultation. The patient is the one with the problem, and we need to treat them that way. You know, we wouldn't ask a patient to drive to a mechanic and help explain what's wrong with the radiator. I don't think it should be the same way with that. Individualizing patient care. This is a picture of William Osler, and again, from my Jefferson roots, this is a British physician who was actually based on Sherlock Holmes, and he was a manic, very precise diagnostician. He focused on the entire patient. He would look at the crease in their ears and evaluate whether or not they had cardiovascular disorders. He would look at the pitting in their nails and determine whether or not they've got some pulmonary disease. And he would look at all of the different things that make up the spectrum of patient care and understand that there is more to this than just, "Doc, my back hurts." The patient is not a lumbar spine. The patient is a 55-year-old daughter, 55-year-old mom, grandmother, sister, brother. This is a person, and we have to understand that there's more things involved than just what we're focusing on as the specialist. So you have to understand, is it organic? Is it an actual physical problem that we can find? I think even more important, can you have the patient describe the pain and the pathophysiology between visits? Does it change? Is it a moving target? I'll tell you what, it is very hard to surgically operate on something that doesn't make sense or doesn't follow the same paradigm each time you see the patient. Does the patient understand what's going on? Do they have an idea of what the problem is? And you have to see how the patient behaves. Body language is one of the most underrated things in the evaluation of a patient. They walk in with their head down, no eye contact. There's going to be some other things going on here than just the pain. Have them stand up. Take a look at how they walk around. Look at how they walk into the room. Who are they with? What are they wearing? Think about all of the things that make them up, because those things are also involved in the evaluation and surgical care of these patients. You got to think about what they're going to be doing 6 months from your laminectomy, not what they're doing right now. And you have to understand that they have lives and they have goals and they have things that they're focusing on. And so I think the behavior becomes a big part of this. Pain is psychosocial. This is something that I really try to help explain to patients. And you have to find the right way to tell patients that I don't think this is a problem that's physically can be taken care of. You know, one of the things we need to focus on is mental health. And I think it's one of the things that oftentimes gets brushed to the side. Because it's easier to phone in a prescription for a narcotic, it's much more easy to just tell the patient that we'll get rid of all their problems by taking out that tiny disc herniation that's not even in the foramen. It becomes more of an act of convenience. And I think it's much harder to get through this part of it, but it's so critical to understand that these patients, when they're in pain, it changes the way they behave. And chronic pain necessitates a longer look than what we're currently assessing, in my opinion. Interventions. Probably the most critical thought here is that you have to be proportional. How long has the problem been going on? The severity of the problem. That should dictate what level of intervention is required. So we shouldn't go right to the surgery. If they've had 5 days of back pain, there's a better than 90% chance that's going to be better in 6 weeks if you did nothing, if you just ignored it and told them to suck it up. Now, you have to have a little bit more touch and poise than that, but I think it's very important to understand that. So I think you really have to think about things as surgery is the last resort, and that it's a team role, and that perhaps you can go up and down the rungs of treatment. You know, if a patient gets slightly better with an epidural and then perhaps sees a chiropractor and feels, hey, I'm doing much better, you can also get back to the epidural again if that's a treatment option. The patient should tell you when they're ready for surgery outside of urgent or emergent problems that are going to create irreversible damage. I live in a world where a large amount of the surgeries that are performed are elective, and you have to understand that. And it's something that I think is challenging for us as surgeons because we become so focused on what we've trained so long on, and we don't take the time to really think about what we're doing and why we're doing it, and more importantly, when we're going to do it. So let the patient get empowered. Have the patient become part of this. You have to understand what the patient's goals of treatment are. What are they trying to do? Is this a 68-year-old man that's trying to walk his daughter down the aisle for a wedding in 3 months? You may want to treat them a little bit differently than the patient who's a 48-year-old weekend warrior that just slipped a disc when he was trying to dunk when he clearly can't do that anymore. And you got to give options. Patients really appreciate a humble physician that takes the time and says, listen, I'm going to go through all these different options of treatment. I will give you my thoughts as to what needs to be done, but it needs to be an engagement. It can't be this paternalism that was something that plagued our society and healthcare of the past. So the other thing is you have to understand that this is how we're going to do it. You give the options. If this doesn't work, then we'll try this. And it's over this span of time. I think having them understand how long the care is going to take and where we think they're going to be is extremely helpful. Empathy is critical to this process, and you have to really take your time to understand what the problem is. You got to figure out the activities, like I said before, and give them time. One of the things that I've gotten into the habit of is anytime I see a new patient, they may be a surgical candidate, and as long as they're not having some severe myelopathic symptoms or something where I am significantly concerned that a temporal spacing of surgery would limit their recovery of function, I'm going to give them time. The microdisc where they're having the severe hot radicular symptoms, I'm going to give them a little bit of time to figure things out. I don't like to sign up a new patient for surgery the first time I met them. I'll give them the literature. Let them call me back. Let them take some time. Talk to the parent who's going to help them out. Talk to the spouse who's going to watch them after the surgery. Make sure that you have the whole team on board. It's not just a patient that gets up out of surgery, gets discharged, and then disappears into the ether. They have to go to a home. They have to figure out how they're going to recover. Things as simple as getting up and down a flight of steps could become a major issue over the post-operative time frame. So it's such an important part of this process, and it's something that I think is very underrated. So the future challenges here is really changing the paradigm. We have to go away from the individual physician of whatever subspecialty and become part of the team. We have to leave Christopher Reeve and we have to embrace Tony Stark. We have to go into the Avengers. We are not Superman. We are a team because the problem is so much bigger than what one person can do. The hard part with this is that you have to maintain efficiency, and that's where you have to build a culture of everybody else involved. It's one thing to have all the physicians on board, but if you do not have the right support system, whether it's your medical assistants, your physician assistants, the x-ray techs, the understanding of everything that's going on, you won't be able to set up something that simply, there's just not enough time in the day. And then you have to figure out the referral basis. So again, right at the bottom of that pyramid is primary care, because they're the gatekeepers. And that's the most important thing. We are sometimes sub-specialized into these small, very specific treatment options. And so we have to cast a wide net and be able to figure out what actually needs to be seen by a subspecialist and what doesn't. And again, the ancillary support is critical. So you need to have an institution with things that assist in the ability to support you. And all of this needs to require trust. So if you're taking care of these patients, if you treat these patients the way you would treat your family members, the trust is going to happen. So it's just a matter of giving that effort. We have to just change the way we think about taking care of patients, and I think this will make a significant difference. It's going to take a lot of work. It's going to take a lot of time, but this is something that once you create the process and the spectrum, it will work out well. I appreciate everyone's attention, and this is my son if he had to listen to this talk at this point. And here are some references for me, and my last slide here just goes through the Spine Center.
Thank you so much, Dr. McKenzie. It was really great because you very well outlined the need for a comprehensive approach towards all diseases, but especially spine. We have some time. I mean, you really sparked tremendous interest in the audience. There's just countless questions, but we'll try to get through as many as I can. What is the most common backache you find in your patients?
I think the most common is paralumbar pain. So they'll point just into the space, just lateral, about 5 to 6 centimeters lateral to midline. So they'll point there, and it generally will come across that area. That backache is almost always axial, and I think, in my opinion, it is often coming from degeneration of the facet joints posteriorly, because again, those are off midline as well. I think a very important thing with the physical examination is palpating those spinous processes, because if they're having pain over the spinous process, there's an argument that that backache and pain that's radiating laterally may actually have a more discogenic component.
Great. Now, in terms of comprehensive spine care, what holistic preventative measures do you think our patients should adopt prior to going to the doctor?
I think the most important thing the patient needs to understand is being able to understand what the problem is and figure out ways to best treat it. So I'll tell patients that the less challenging, less invasive things, frozen peas on the back and see how they do at night is fine. I also ask patients to think about what positions make them comfortable and what positions make them uncomfortable. So some of the things are use of heat or ice is something that's very reasonable. And then over-the-counter medications with the right understanding with the primary care, such as Tylenol and anti-inflammatories for a short course, is probably the most reasonable things to start with. If you want to go more holistic and less medication-based, stretching and things of that nature, I think have been helpful. There have been studies that suggest that yoga and other kinds of ways in which you are really challenging the flexibility of your low back and even in your neck can improve things significantly.
From a primary care standpoint, is there any value to obtaining plain lumbosacral x-rays for the evaluation of atraumatic pain? And if yes or if no, what should the initial radiographic evaluation be?
I think that is an outstanding question because there's such an important timing to that. The x-rays, if you have back pain that's been going on for less than, say, 4 weeks, I do not think you need an x-ray unless there are findings of radicular symptoms. So if that's the case, give it some time. So I've talked numerous times to some of the many outstanding Redeemer primary care physicians, and I explained to them that my workup is after 4 to 6 weeks of this axial back pain, even if it's not radicular, it's not unreasonable to get 4 views. You get the AP lateral and flexion extension views. The spine is a dynamic process. We don't think of it that way, but the flexion extension views are going to help us assess if there's spondylolisthesis or if there's any difference in the facet strength and quality, which can really tell you much more than just the static AP and lateral. They should also always be weight bearing. I think that is one of the most important things. Sometimes people take these x-rays supine, it doesn't give you nearly as much information.
Well, that's about it, Dr. McKenzie. Jim, that was awesome. I mean, back pain is something probably most of the audience deals with on a daily basis, and you really helped outline the initial evaluation, and again, the really importance that Holy Redeemers established, this multimodality approach, a comprehensive approach towards a disease that you could see affects so much and is so cost effective. or cost problematic. Thank you.
My pleasure.